Welcome to the UT Health East Texas Virtual Education Series. Today's presentation topic is endometriosis, What is it? Featuring Dr. Teri Lynne Baumgartner, Board Certified Obstetrician and Gynecologist at UT Health East Texas Physicians in Athens.
Hello, I'm Dr. Teri Lynne Baumgartner. I'm a UT Health physician in Athens at the OB-GYN clinic here. I'm here to talk to you today about endometriosis. Endometriosis, what is it? Signs and symptoms, diagnosis, and treatment. First of all, endometriosis, the definition is a condition in which endometrial glands occur outside of the uterine cavity. Where are these glands frequently located? The ectopic endometrial glands can be located in any pelvic structure and further away, including the diaphragm or even the lungs. Most of the time, about 67% of the time, the lesions occur on the ovaries. Sometimes they'll be on the tubes. About 30% of the time it's in the pouch of Douglas, which is just behind the uterus, and about 21% of the time they occur on the bladder. The uterosacral ligaments can often be involved as well. This happens about 46% of the time, and this is why women have pelvic pain with intercourse, because those endometriosis lesions are located on the uterosacral ligaments. How prevalent is endometriosis? Well, it varies with the population. Typically, about 10% of reproductive age women will have endometriosis. Teens who have genital tract anomalies will have endometriosis 40% of the time. It's reported to be prevalent about 50% of the time when a woman has infertility. For people with pelvic pain, endometriosis is the cause approximately 70% of the time. Endometriosis is estrogen dependent, and the glands that are located outside of the uterus grow in response to estrogen. Well, how do women present when they have endometriosis? Frequently, they will come to the office complaining of pelvic pain. That is the number one symptom that we see. They have pain with their period, they have pain with sex, sometimes they have pain with bowel movements, sometimes they have other issues like infertility or even pelvic masses such as endometriosis or endometriomas, which is a ovarian mass that's filled with old blood and frequently called a chocolate cyst. So what are the factors associated with endometriosis? Well, women who are of white and Asian descent tend to have an increased risk of endometriosis, while women who are Black or Mexican or Hispanic descent tend not to develop endometriosis. Women who have never had a child tend to have endometriosis more. Women who start their period before age 11 frequently get endometriosis more. Women who have short menstrual cycles, meaning their cycles occur every 3 weeks instead of every 4 weeks, tend to have endometriosis more. What are things that decrease the risk of endometriosis? Well, women who have had multiple children tend not to have endometriosis. Women who have breastfeeding for a prolonged period of time, greater than 6 to 8 weeks, tend not to have endometriosis. And women who start their period late, greater than age 14, tend not to have endometriosis. Well, what causes endometriosis? How do people get it? Basically, it's multifactorial. There are many things that can contribute to the cause of endometriosis, but one of the main theories that's out there is called Sampson's theory, and that's where you have retrograde menstrual flow out of the fallopian tube into the into the pelvic cavity. That's why most of the time the glands that are outside the uterus are on pelvic structures and not further away, like on the diaphragm. This retrograde menstruation causes multiple adhesions and inflammatory responses that can be either deep infiltrating lesions and cause pain and even kinking of the bowel or kinking of the ureters. Also, the lesions can be minor and just cause they're called powder burns. It looks like little bitty spots along the pelvic cavity when we look in there with a laparoscope. So, 80% of patients with endometriosis will present with pain. Usually they're between 25 and 35 years old. Usually they complain of not only pain with their periods, but their periods may be heavier and they have pain with sex. 25% of women will have infertility when they have endometriosis. Well, why does this happen? Because the endometrial glands will cause adhesions and kink the tubes or cause inflammation, and sometimes the mucus and the fluid that is normally in the glands will get trapped there, causing a hydrosalpinx. And about 20% of women will present with an ovarian mass. These are called endometriomas, and like I said, these are fluid-filled cysts with old blood. It looks like a chocolate. It looks like it's filled with melted chocolate when we look on in with a laparoscope. So when we do a physical exam on these women, what do we find? Well, on exam, we will frequently find tenderness in the abdomen. And when we do a bimanual exam, where we palpate the uterus and the ovaries and tubes, the patient will have extreme pain. Sometimes there will be nodules on the posterior fornix. Sometimes when we do a bimanual, we feel an adnexal mass. We can tell that the ovary is larger than what it's supposed to be. And many times, if they have deep infiltrating lesions, their uterus will be stuck. It'll be fixed. It won't be mobile. And that contributes to the pain they have with sex as well. So what labs can you order to find out if somebody has endometriosis? There's the problem. We don't have any good lab work to tell if someone has endometriosis. Well, are there imaging studies? Yes, there are. Sometimes on an MRI or a transvaginal sonogram, we may see those chocolate cysts or endometriomas. We may also see nodules along the rectovaginal septum or even on the bladder. So how do we make the diagnosis of endometriosis? The definitive diagnosis is made through surgery. We have to have a biopsy of an area that looks like it's endometriosis. We send that biopsy to the pathologist, and histologically he confirms that this is endometriosis. Not every woman can afford to have surgery. Not every patient who has pelvic pain can be off work to have a procedure done. So what do? When women come in and they have symptoms of endometriosis, we can make a presumptive diagnosis. And frequently we start them on birth control pills and anti-inflammatories. This is a first-line treatment for someone with pelvic pain who we suspect may have endometriosis. There are little side effects to either one of those, and many times the woman's symptoms will improve when we use those medicines. How do we know for sure if they have endometriosis? The only way to make the confirmative diagnosis is by surgery. We do a laparoscopic procedure where they have a small incision in their belly button. We put the camera in and we can look around the pelvis, and anything that we see that we deem could be endometriosis, we can photograph, take pictures of, and then take a biopsy of and send it for pathologic review. Anytime we're treating endometriosis, we have to individualize every patient's treatment. Every patient's different. Some patients have already completed childbearing and aren't interested in becoming pregnant. Some patients are having problems with infertility and don't want to be on birth control pills for their treatment. Therefore, we have to consider their wishes, the symptoms that they present with, the location of the lesions that we're finding, what their reproductive desires are, and the medications as well as the side effects and the cost. So like I said, the primary treatment that we typically start out with is birth control pills and anti-inflammatories. However, if a woman wants to become pregnant, we forego the birth control pills. If the patient has severe symptoms or recurrent symptoms and does not respond to the birth control and the anti-inflammatories, we give them a trial of GnRH analogs. These are Leuprolide or Lupron, Trelstar, and Zoladex. If the symptoms still do not improve, then we try aromatase inhibitors. These are mainly for refractory symptoms, and those are Femara and Arimidex. Frequently, we used to use a medicine called Danazol. However, it has many side effects, and we have tended to back away from that treatment. There is a new treatment out. It's a GnRH antagonist. It's called Orilissa, and I personally have seen wonderful results with this medication in my clinic. It suppresses the LH and FSH and leads to lower estradiol and progesterone levels. It does, however, have side effects. Those are bone loss. So women who tend to have osteoporosis in their family may not want to use this medication for a prolonged period of time. It can cause abnormal liver tests, hot flashes, night sweats, headaches, and mood changes. So if a patient doesn't respond to medical management, the next thing to offer is surgery. Most people who want to continue childbearing or have problems with infertility will have conservative surgery. This is done laparoscopically, where we insert a camera into the abdomen and we are able to survey the complete pelvic structures. Frequently, we will see little red lesions or cleared lesions. Sometimes we see something called powder burns. It looks like little grayish lesions dotted across the pelvis. Once we've determined where these lesions are, we can desiccate or remove these lesions. Frequently, this will help the patient with their infertility issues. Sometimes it doesn't. However, once a patient has completed childbearing, we frequently recommend definitive treatment. Definitive treatment would be the removal of the uterus with or without removal of the ovaries. If the patient is close to menopause, we frequently recommend the removal of the ovary as well as the uterus. Sometimes during this procedure, the endometriosis implants will form big cysts on the ovaries called chocolate cysts. And in that case, I would tend to want to remove that ovary rather than leave it behind. In conclusion, endometriosis is a lifelong condition. It can be diagnosed through history, signs, and symptoms. But to confirm the diagnosis, you have to have a histologic sample of a lesion. There are many treatments available, both medical and surgical, and women can benefit from seeing their physician. Their life can be improved by treating their symptoms, and I wholeheartedly recommend, if you are having problems with pelvic pain, pain with sex, or infertility, to seek treatment with your OB-GYN. Here are a few questions we received. Can you ever completely get rid of endometriosis? The answer to that is Not necessarily. Women frequently will have definitive surgery where they have had their uterus and their tubes and their ovaries removed, yet they still have endometriosis implants, and that can still result in pain. If they get on hormone replacement therapy, it can exacerbate those implants and even cause more adhesions and inflammation. Can I take medicine for it? Yes, you can. There are lots of different medicines. The first one we usually recommend are nonsteroidal anti-inflammatories and birth control pills. If you don't respond to that, we use GnRH analogs. And we can use the GnRH antagonist or ELISA. Then the next step after that would be an aromatase inhibitor. What are the side effects? Frequently, with the birth control pills and the NSAIDs, sometimes they get GI upset, sometimes they have a little weight gain or breakthrough bleeding between cycles. Those are common things that we see with those medications. With the GnRH analogs, they'll have hot flashes, night sweats, mood swings, and with the aromatase inhibitors, they can have all those symptoms as well, plus bone loss. So those are the side effects we frequently see with those medications. Can endometriosis affect your ability to get pregnant? The answer is yes, it can. Endometriosis is one of the leading causes of infertility. Approximately 50% of women with infertility will have endometriosis. Does endometriosis worsen with pregnancy? The answer to that is actually no. Many women feel better when they get pregnant. Their hormone levels are more stable, they have less inflammation. It's almost like a complete turnaround from the symptoms that they had before they got pregnant. So I like it when patients who have endometriosis get pregnant because typically they feel better, and I'm happy for them because they're not infertile anymore.
We hope you enjoyed the presentation today. For more information about scheduling an appointment with Dr. Baumgartner or one of our gynecologists near you, call 903-596-DOCS or visit uthealthiestexasdoctors.com. Our next virtual seminar will be announced soon. Follow us on Facebook to stay up to date on upcoming events and seminars. Thank you for joining.